Happy St. Patrick's Day. As an update, I wanted to provide note that our team is working to finalize our revised nursing home visitation guidance to reflect the federal new CMS guidance that was announced late last week by them. We hope to have that guidance completed in the next day or two, after which we'll be providing it with the hundreds and hundreds of long-term care facilities that we have around the state. And we're also going to be holding a virtual meeting with our state's assisted living facilities so that we can help them understand the guidance and answer the questions that they may have. The finalized updated guidance will, of course, be updated and made available on our website for everyone to see and reference and ask questions about. So as another update, yesterday we launched an improved version of our vaccine dashboard. I'm not sure if you've had a chance to look at it yet, but it is more powerful. The front page appears very similar, but you'll see several tabs at the top of that document, and that will allow you to navigate to much more data that we think is broken apart in a way that's easier to understand it and easier to then convey to your readers and viewers. So as you look at it and you have questions, we also have invited a member of our data team, Emma Craig, and she is part of the mastermind group behind this and helps manage that dashboard. And so she'll be on the call, or she is on the call with us today, and she can help answer any detailed questions that you may have about it. Initially, when we first began receiving and administering vaccine back in December, we also created a vaccine allocations page. That web page is the one with the blue boxes, and you can see by facility PDF lists that show the number of allocations and percent utilization by facility. And now that we have an updated dashboard that's live with a bit more information than we had a month ago, our goal is to have most of that information from the allocations webpage represented in the dashboard instead, so that we have a single source for our most up-to-date content and accurate vaccine information at the same time. As an overall update, we are very happy with how our 1B rollout is going across the state. Vaccine does remain very limited. So although we did receive a slight increase in doses this week, as we have in the past couple of weeks, we know that people aren't able to make appointments as quickly as they may like to, but I know our providers are working really hard to administer the vaccine as quickly as they can do so. So we plead, please do not wait. Continue to reach out to try to schedule your appointments with a vaccine provider, hopefully near you. And regardless of individuals' ability, Christy, will you?
Yeah, Nick, I'll mute. Just keep talking. I'll mute.
Okay. All right. So as a reminder, we still need to wear our masks and physically distance, despite having a fair amount of vaccine out there and an ever increasing number of people getting vaccinated. I would argue that I believe that you'll find that our website shows that even better, but we must continue to mask, physically distance, even after getting the vaccine. So now that the vaccines are here, that doesn't mean that we need to stop taking our basic disease prevention actions that we know work and that have proven to be effective. This virus is still, frankly, everywhere. It's in our communities and it's continuing to spread. People are still getting sick, and unfortunately, additional individuals will die from this virus. We are beginning to see what might appear to be the end of the light at the tunnel, with more vaccine coming to us every day. But we all need to continue to do our part to prevent the spread of this deadly virus. So with that, Christy, I'll stop and we can take questions, I believe.
Thank you, Nick. Our first question that was submitted is actually for Dr. Bell. I've got two questions, Dr. Bell. Can people trade vaccine appointments with someone else? In other words, if someone makes an appointment but thinks that their loved one needs it more, could they swap?
Good afternoon, everybody, and thank you, Christy, for sending forward the questions. We do not recommend the swapping of an appointment, and the reason is because when someone schedules an appointment, We do ask them to enter information that is specific for them. We're collecting demographic information, the age group. We are hoping that people are completing their reason for being vaccinated, which group they fall into. And this is how we monitor how we are administering the doses by category of eligibility. So if they swap that appointment with someone else, the information that was entered into the appointment system won't match. And so, no, we do not recommend that people can swap off and give their spot up to someone else because it is personally appointed. If that's done through the appointment system.
Okay, thank you, Dr. Bell. Nick, how does DHEC keep track of the number of appointments that are going unscheduled? Is the agency doing anything to draw people's attention to where doses are available?
Sure. We are doing everything we can to make people aware of where doses are available. On our website, the vaccine locator in particular, which people call the red and green dot map, we update that multiple times a day. And the providers are indicating to us as to whether they are accepting appointments or not, which allows us to switch between red and green or vice versa. So many providers do use their proprietary systems for scheduling. That certainly is of great advantage to the providers as well as to the patients making the appointments because it's integrated right into their normal service delivery system. And so that is good, but of course, DHEC does not know on any given day which facilities have what amount of unused appointments, where those slots are, exactly what time those slots are, because of course those are managed by the providers. As we begin to offer CVAS, the vaccine appointing system that our clinics have been using for other providers, we will have some additional visibility on that. But right now we're trying to do everything we can to make it as visible to individuals on our website and as easily accessible to the public.
And has DHEC opened CVAS up to other vaccine providers to use for scheduling appointments? And have any opted to use CVAS as their scheduler?
Right. I guess I almost answered this question and the first question, but indeed next week we will begin offering that up. We have determined that CVAS does seem to meet most of the needs that most providers have for those that don't have their own system or who desire a better system. And so we will begin making that available to providers next week. But as far as others who have opted to use it, the only others that we have offered it for use, we did offer it for the large clinics that McLeod was providing. So the Darlington Speedway was done through CVAS. And I believe 2 of their clinics in the Myrtle Beach area were also, that very same week, they were large clinics, were also done that way. We understand that they generally had a very good impression of it. And so that was another good test for us. And so we had some additional meetings and some additional discussions with our IT folks, as well as some of our staff who are working with providers. And it does seem like that's going to be the best system to offer for use to people, which we will begin to do next week.
So how many people typically visit DHEC's vaccine locator per day?
So thanks for providing this question ahead of time. We were able to pull that number. It's in the past 30 days, we've had 547,290 total views, and that averaging about 18,000 daily views. A little over 18,243 daily views of the site. So over 500,000 in the past 30 days is pretty amazing, and so clearly it is serving one of many purposes.
And Nick, what does DHEC make of unofficial tools to find appointments? Tools like the vaccine spotter. Is there anything wrong with using these tools, or any words to the wise that you'd like us to pass along?
Sure. Technology is amazing. I'm always impressed at how IT companies can harvest information from existing resources. And so I commend them for that. I think everything that we have at our fingertips is of use, and as long as we use it smartly. So I would just say, to the extent that individuals can try to survey those sites and see to what extent they are that it's updated information, because the information does change so quickly. But I certainly am not going to say that there's one best location that everybody should go to. I think there's an awful lot of resources. We at dhec try to provide them as timely and as thoroughly as we can. But other people may prefer other sites or find them, sometimes depends on the individual, easier to use. And but just make sure that I would encourage people to go to sources you've heard of before and to use ones that seem to be updated routinely.
Thank you, Nick. Will the vaccine call center at dhec schedule appointments for people, or do the representatives connect the person to a possible vaccine provider? We've heard varying accounts from readers on this, so we'd really appreciate you clearing it up.
Sure. They can do both. So we're speaking about our vaccine information line, the toll-free number that we offer, almost as an alternative to some extent to using internet resources or as an assistive resource in addition to those. And so they can definitely do either, frankly. The vaccine information line will assist callers in making appointments for at least first doses, because sometimes second doses are handled when an individual gets to that site. But at least for first doses of vaccine, at any of the providers that's listed on our vaccine locator site, our operators will assist people in making those appointments if they need to, and to the extent that they the caller is willing to or desirous of us doing so. Keep in mind, though, that sometimes you go to a site like CVAS and you can just do it then and there. Sometimes it requires additional, for instance, sending an email to a provider, and then that provider will email back. That can sometimes take much longer than the caller has to wait online. Sometimes, though, there's a phone number available. So in any way that we can help them on the vaccine information line, if they would like us to assist them, we will work with those individuals to step them through the process to the extent that that provider's system allows us to do that.
Thank you, Nick. Dr. Bell, I've got a couple of questions for you now about vaccine efficacy. The first one says, are antibody tests a measure of whether a COVID-19 vaccine was effective? We are hearing from a reader who says his doctor told him to behave as if he didn't get one because his antibody test returned negative. Would dhec suggest people contact vaccine providers to inquire about leftover doses? Why or why not?
Okay, I'll take the first two parts of that question first about the antibody tests. And antibody test is not a reliable way to determine if a vaccine worked. Particularly some of these commercial antibody tests may be detecting a different antibody than the ones that the vaccine may stimulate your body to produce. So for example, vaccination can stimulate your body to mount an immune system in a variety of ways, from different kinds of antibody responses. And there also may be cells in your bloodstream that help your body mount an immune response. So if you get a commercially performed antibody test, it can be looking for a different antibody than the one that the vaccine has worked to stimulate in your body. So you can have a negative antibody test, but actually have mounted an immune response. And for that reason, we don't recommend that people attempt to get an antibody test to determine whether or not the vaccine has quote unquote worked for them, because you can in fact be immune and have a negative antibody test. And I think the second part of that question as to whether or not we recommend people contacting their providers to find out about leftover doses, if that was the question. And first of all, what we're recommending for providers so that we can minimize any vaccine wastage is if they set up some sort of protocol, some sort of a call down list or maybe a waiting list, that if they should have doses left over, then individuals can be contacted and said, if it's convenient for you to come in within the next time frame or something like that, we may have doses available for you. But if individuals are going out, since we have such a wide variety of provider types and settings where the vaccine is available, we don't necessarily recommend that people go out and ask providers about leftover doses. That's not a very systematic way of actually finding leftover doses. So a more planned out way would be for individuals to perhaps work directly with a local pharmacist that's convenient with them, or work with their own healthcare provider and ask, do you have some sort of waiting list that I could put my name on? And that would be a better way to potentially get access to leftover doses.
And Dr. Bell, could you define for members of the media what we mean by efficacy?
Sure. So of course, there's a lot of talk about efficacy with the different vaccine products that are available now. And actually what efficacy means is a particular endpoint or a specific result that well, of course, for this one, we'll use vaccine manufacturers, are looking for to test how well the vaccine worked under specified conditions of a clinical trial. So the endpoint or the outcome that they're looking for could be anything from prevention of infection, or for the purposes of the vaccines that are currently available, they looked at endpoints of prevention of severe disease. And so under controlled settings of a specifically enrolled population, under specific clinical study design, that's what we look at for efficacy. And I just want to contrast that with what we mean by effectiveness, because outside of a controlled setting, it's what the real world experience with a vaccine will be when it's not under a clinical trial where they have enrolled a specific population of individuals. It's how these vaccines perform in the real world. So there can be a difference between the efficacy and the effectiveness in the general population.
And Dr. Bell, does a 95% efficacy really mean 5 out of 10 people who get the shot will get COVID? And why isn't it fair to compare efficacy rates from different clinical trials to each other?
Well, sure. The first part of that question, I hope I answered in part, because if you're looking at efficacy under the conditions of a clinical trial, you may, what was reported out for the vaccines, Moderna and Pfizer, is in that range of 95% efficacy. That doesn't necessarily mean in the real world that 5 out of every 100 people who are vaccinated will not be protected, because that's not real world experience. You will find different variations in people's immune response. And in fact, in some subpopulations of the clinical studies, they had higher efficacy rates in subpopulations. So no, that doesn't mean that 5% of the people in a population will not be protected. And then in the second part of that question, Christy, remind me what.
Yeah, sorry. Yeah, it's okay. So the second part was, why is it not fair to compare efficacy rates from clinical trials to each other?
Right, thank you. And because I mentioned that the clinical trials are performed under very specific conditions. And in fact, we are cautioning against attempting to make head-to-head comparisons against the most recently approved Janssen vaccine as compared to the Moderna and Pfizer vaccines, because they were tested at different points in time. They were actually tested in different populations of people, when there were different strains circulating in those different populations of people. So in looking at the efficacy of those those various vaccines, they can't be compared they cannot be compared head to head, because they were essentially tested under different conditions. The clinical trials were conducted under different clinical conditions, and so you can't make direct comparisons about the results, because they were looking at different population groups, different time frames, different predominant strains circulating under some circumstances.
Thank you, Dr. Bell. Nick, I've got a set of questions for you. The first one is pharmacist and senator Ronnie Kremer said at a public joint bond review committee meeting this morning that South Carolina is only receiving 5,700 doses this week allocated by the CDC or the federal government. Can you speak to what he may be talking about?
Certainly, I would definitely suggest speaking to him, but I did actually hear the Joint Bond Review Committee this morning, or watch it, and I did hear that comment, and certainly since I believe him to be a pharmacist, I think he was speaking about just the Janssen doses. That is indeed the number of Janssen doses that we have available to distribute this week, is 5,700. And so those are going out to independent pharmacies primarily because they got the first push from us the previous week with Janssen vaccine. So I can only imagine that is probably what he was speaking about, was solely the Janssen vaccine, which is coming to the local pharmacies.
Okay. And South Carolina's weekly allocation is only increasing by 1,000 doses next week. In the past, it has been stated that incremental increases were expected. Is this increase enough to keep DHEC's timeline on track?
Sure. We do expect incremental increases primarily for Pfizer and Moderna, but we expect significant increases for Janssen most likely the week after next. So those are the types of increases, as much as 5 or more fold increases over what we're currently receiving. It's those types of increases that are going to keep us on track and keep us where we need to be in our schedule.
Dialysis clinics are advocating to be given vaccine doses to administer to their patients. Have any dialysis clinics applied to be, I think this means vaccine providers in South Carolina, or administrators?
Right. Yes. Indeed, we have had a number of them apply to do that. So they go through a process basically to apply to administer the vaccine, and then we get appropriate documentation from them, provide them appropriate training and preparation to be able to administer the vaccine. And then that's a process that we call activation, such that when we have vaccine, we'll be ready to push the vaccine out to them. So once they're they enroll by us, and then when we activate them in the system, that means they have done everything they need to do in order to receive vaccine, other than us actually having the vaccine. So we have had 23 different dialysis locations that are activated in our system. And right now we're just waiting for increases in vaccine to be able to add them.
And Nick, that's a perfect lead in, because I've got 2 more questions about dialysis clinics. So does DHEC have the final say on which administrators are approved, or is that decision made by the federal government?
No, I would say very luckily that decision is being left to the states to make.
And then I think you've already answered this, but the question was, if dialysis clinics are among the approved administrators, why haven't they received any doses?
Yeah, they are among the ones. They are ones that we would love to be sending vaccine to. The challenge right now is still supply, and we just can't spread the vaccine but so thinly around the state. If we gave it to everybody around the state who could possibly administer a vaccine, it would not be a feasible process. We need to be able to give some reasonable quantity so that to providers, so that clients have an expectation that if they're providing today, they're probably going to be providing tomorrow, if you will. And so it's just it's a math problem right now that we're just looking and waiting for more vaccine. And absolutely, to them and others like family practices around the state, we're very anxious to be able to send to many of them as well.
And Nick, we do have lots of questions today specifically about allocations, but how has the vaccine supply in South Carolina changed since the year start, so since the start of 2021, and do you know where it is headed?
Yes, definitely. Well, let's talk about where we've been. So it was just prior to the beginning of the year, and for about a solid month there, that our allocation was pretty level. we got Pfizer and Moderna both in approximately just over 30,000 doses for each of them. So we were sitting at about 60,000 first doses being sent into the state every week. Like I say, we were there for weeks, but over the past month or a little more than a month, we've more than doubled. And we've doubled through the addition of both Moderna and to a greater extent Pfizer. And now we're beginning to see Janssen deliveries. Small. The first week was larger, but the past couple weeks, as anticipated, have been small. And we expect that in the next couple weeks to increase. And so really looking forward to having sizable amounts of Janssen, much like we now have sizable amounts of Pfizer and Moderna.
Okay. And Nick, can you speak to or reiterate how many doses South Carolina receives each week now?
Sure. We, like I said, at the beginning, we were getting just over 60,000 doses, in the neighborhood of 63,000 first doses each week. And now we're at the point where, at least in the current week, the current distributions that are going out will be, well, let's see. Let me make sure I've got. So the vaccine allocation that will be shipped out next week will be in the neighborhood, well, it'll be at exactly 122,360 doses that are coming to the state. And so that's Pfizer, Moderna, and Janssen. And then there's an additional 12,600 that's coming directly from a separate federal allocation going out to our large pharmacies that are part of that federal pharmacy program. Right now, that's CVS and Walgreens, soon to be Walmart.
And just a point of clarity, Nick, so for the Pfizer and Moderna, those are first doses, or yes?
Yeah,
okay.
Everything that I've mentioned here have been first doses. Perfect. Second doses are pushed based on the number of doses that were shipped to us either 2 or 3 weeks ago. And as I think most of you know, we're now doing that same allocation to the facilities, particularly the hospitals, who are routinely getting fairly consistent amounts. And so we're pushing to them whatever we ship to them in first doses to, 3 weeks ago for Pfizer.
Okay. And Nick, I know we've got a web page that kind of talks about the 5-step vaccination process from when we get vaccine from the federal government and then how we allocate that to providers. Sure. This reporter was wanting sort of an overview, so we can certainly provide that page to them. But specifically, they're asking what's given directly to providers and then what public-private partnerships are still active.
Okay. So sure, it can be a little confusing, no doubt about it. So the best way to think about it is that the Pfizer, which is going primarily to hospitals, also to doctors' care, those are must be handled must be kept ultra cold if they're going to be kept for a significant period of time. So that's why we started with the hospitals largely with the Pfizer. So of the Pfizer that's going out this week, and so this coming week's allocation for the shipments for next week are going to be 67,860 doses. So of those 67,860 doses, all but about 7,000 doses are direct shipped, ultra cold, to those facilities who have the capacity to keep them in ultra cold storage. The approximately 7,000 doses that will not be direct shipped to the facilities are shipped to dhec's redistribution site. And we then redistribute those doses to primarily hospitals, or almost exclusively hospitals around the state, who don't have the capacity to store ultra cold. In other words, we break up the shipments into smaller quantities. Typically, it's to smaller hospitals, and we ship to them through our redistribution site. We have sometimes referred to it as the RSS site. It's receiving storage and shipping site. And so we redistribute those 7 out to those facilities, typically smaller hospitals. All Moderna and Janssen are direct shipped to facilities that we determine that we work with facilities ahead of time to figure out how much they're getting and through a normal allocation process, but those are all direct shipped. The public-private partnerships, I assume we're referring to the federal pharmacy program, and that's a program where I mentioned it comes straight from the feds that are from a separate federal allocation of vaccine, not the state's allocation that I've been speaking of. And so that most recently, as I stated earlier, was the 12,600 doses, and that's been going out to CVS and Walgreens, and we understand Walmart is being added to that federal allocation program as well. So they will begin probably next week, I'm guessing. I don't think they got any this week, but they'll begin to be receiving allocations directly instead of us using vaccine from our state allocation, sending it to those Walgreens locations, or Walmart location, excuse me.
Thank you, Nick. You've been a champ. That was about 10 questions in a row for you. So we're going to give you a break. And Dr. Bell, I've got a couple of questions for you. The first one is, has the phase 1B demand been lower than phase 1A from mid-January to early March?
So that might be another example where it's difficult to make a head-to-head comparison. For a couple of reasons, where we were back in January in phase 1A, we had those who were eligible. It was about 600,000 population there. We had fewer providers available and less vaccine supply available. So where we are now is that we have opened it up through the phase 1B eligibility. There are now about 3.2 million people in that new group, but we have fortunately far more providers who are available to offer vaccine appointments. And as Nick has stated so well for the last 10 minutes, we've had an increase in our vaccine supply, but still not yet enough to match the demand. So we recognize that people are still somewhat challenged in finding a vaccination appointments in the time frame with the speed that they'd like. But we are encouraged that our vaccine utilization is very high, that the number of appointments available are more readily available. But comparing where we were in January and where we are now, we just have so many differences in what to compare, but particularly in the proportion of the population that's now eligible. So we fully expect that the demand for those appointments is still quite high, and we're just looking forward to those those estimates that we will continue to get incremental increases in the vaccine supply to meet the need and the expectations of as many people as possible as soon as possible.
And Dr. Bell, under DHEC's current residency rule, would there ever be an instance when an out-of-state resident is denied a vaccine in South Carolina, or are out-of-state residents free to cross into the state for the sole purposes of receiving the vaccine?
Well, we're asking people to do self-attestation for their eligibility. We're not asking for identification. We're not asking for confirmation of residency. And really our goal from just the global public health perspective is to get as many people vaccinated as quickly as possible. We know that we have soft borders between states and between counties. So we are not looking to impose really strict residency requirements on people who can be vaccinated. If they found an opportunity to get an appointment and they're eligible, then we're not working to be particularly discouraging.
Thank you, Dr. Bell. Nick, I've got 2 questions for you about the homeless population. Can DHEC provide more information about its plan to vaccinate the homeless population? And then secondly, how is DHEC connecting with that group, and when will they be administered doses?
Sure. We are working with homeless coalitions throughout the state through a couple means. One, our Office of Social Work, and also our COVID response team. We refer to them as our incident command structure. So both that team and our Office of Social Work is coordinating with coalitions where they exist, but also with medical providers who already serve that population. And so there are some large providers. I know Prisma, for instance, has done some work with the homeless population. There are many large providers that are already vaccinating the homeless. So we're trying to do it in a holistic approach where we work with those who work with the homeless. We work with providers who may already be working with the homeless. And certainly we do hope that as we get more Janssen vaccine, that will be a resource for all of us at dhec, as well as our providers, potentially some of our providers around the state, because we realize that they may be a bit more transient and more difficult to schedule, and that Janssen single dose vaccine may be one that would be well indicated for them.
And Nick, this is going to be the last question before we open it up to reporters. So according to the CDC's data table on doses administered per 100,000 people, South Carolina ranks 42nd, not counting U.S. territories. Can you speak to why that is?
Sure, and I did have a chance right before the call to take a peek at the numbers. So most states, and you're right, the reporter here is referring to a rate, so per 100,000 individuals. And so most states, when you look at them, are between either the high 20,000 per 100,000 vaccinated to the high 30,000. So somewhere between the high 20s and the high 30s. When I just looked at South Carolina, we're a bit below, just below 32,000 per 100,000. I will say that we have improved significantly in that list over we've had some really good recent gains over the last few weeks or maybe month. We were down near the very bottom of that at the beginning. So there's a variety of reasons for this. One, and I would ask you to keep in mind when you look at that list, there's also some states that, and territories in particular, that are very high on the list. Some of the most remote states, and territories, Alaska, the Marianas Islands, I think the Dakotas as well. Those states that are more remote, or those territories more remote, actually get monthly allocations. So their rates will vary quite a bit, and so sometimes be very high, but sometimes also then drop because they maybe got their monthly shipment, for instance. So there are also the states that have, a bit more, probably less than, we have probably a little bit less than, I'm going to guess maybe around 10,000 or so doses to pull from the long-term care facilities. So those efforts, as you know, probably are concluding near the end of this month. And so we'll have a bit more to pull there and be able to use in our population. So that's it's a very small portion of the additional doses that we would have to use, but that's a contributing factor, certainly in South Carolina. We're also doing, and that's a good thing. I remind people we want to do everything we can to make sure that there aren't any supply problems that in any way impact those who are most vulnerable among us, and those are the folks that are in our long-term care facilities. So we're also doing an awful lot to onboard as many providers as we can and disperse the vaccine as widely as possible. You may have heard me speak in the past about our need and our desire, and we believe our residents' desire to get as close to them as possible with the vaccine. So that's good that we can get close to people, but in onboarding additional providers, it also means that oftentimes it does take them a number of days to kick off their efforts. So there may be, some days delay. And as we've onboarded, 139 additional pharmacies, independent pharmacies in the last week and a half, it's taken, rightly so, some of them a little bit of time to get up and going. Well, in the numbers, when you look at administered, that can impact us slightly, again, in addition to the other things that I've mentioned here, and would indicate that potentially our rate is a little bit lower. But as I say, we've been climbing in those standings. I anticipate we'll, generally speaking, continue to climb as we get providers onboarded. We've now activated all of the providers that had enrolled with us. That doesn't mean they're yet receiving vaccine, but it means we're ready to send them vaccine as soon as we have, just as we've done recently with those independent pharmacies as an example. So it is a balancing act trying to get out to as many places as possible and to ensure that individuals are using, that providers are using the vaccine as efficiently as possible. And I will just add that if you've watched our utilization rate for Moderna in particular over the past, say, month, it's gone up significantly. There's a lot of variability earlier where the Moderna utilization rate was in the 30, even down to 20, 30, 40%, dependent upon the time of week and when the deliveries were made. And I think if I looked earlier, you could look on our website on our vaccine tracker or dashboard right now, and I believe we're well into the high 60s, if I recall, late yesterday or early today. So we're doing a much better job. Really proud of our providers around the state, but we're also trying to continue to provide it to new providers as we have that additional vaccine.
And now we're going to open it up for live questions. If you have a question, please raise your digital hand and I will call on you by name or phone number. Mike Ellis, you've got one question. Please ask it.
You had mentioned new vaccines coming online really helps. Are the estimations for the example, the early May, is that based on new vaccines coming online? And given the AstraZeneca developments, is dhec concerned about making those early May targets?
And the May targets, that which you're referring to, the Biden administration?
Both the Biden administration, and I believe the last one for us was May 3rd, if I'm not missing an update on that.
Nope, you're exactly right. It certainly is. Just making sure I understand what you're asking, or understood what you're asking. Yes, we certainly, we couldn't, for instance, today open it up to 1C or phase 2, for instance. That would not be a wise decision and is not warranted. And so we will need additional vaccine to make that happen. And absolutely, we get additional vaccine every week. We're going to continue to communicate with our providers and understand how quickly they and readily they are able to fill their appointments, how much demand there is, how many complaints they're getting about people not being able to get their vaccine. And yes, as we get additional weekly vaccine, that will of course help. And any additions to that weekly vaccine, for instance, the Janssen that we anticipate in the next couple of weeks, will greatly help us. So. Right now, I think the Biden administration's interest was in making it available, not necessarily that everybody has it by May 1st, but making it available to everybody by May 1st. And our plan says, that came out a bit before they announced their May 1st date, but happens to say May 3rd. We won't quibble over 2 days there. But yes, we are certainly hopeful with increased vaccine supply that we will be able to remain on target with those opening dates. But they are targets, and and we ask that people be understanding if we have to flex it a little bit. We're only doing it what we believe to be the best for our residents.
I'm sorry, but if the AstraZeneca is or isn't approved, does that affect the targets for you guys?
Sure. It certainly, they have to go through the same emergency use authorization process that everybody else does. And it would, if we happen to get some of that prior to either of those two upcoming dates for 1C or 2, that we'll certainly take that into consideration, but it will certainly help us.
Are there any other questions from members of the media? Anna, did you have a question? Any members of the media with questions, please raise your hand. I'm not sure if we're having technical difficulties.
I'll try to raise my hand, Christy, and make sure it works. Here we go.
Yeah, okay, thanks for that, Nick. I appreciate it. Anna Dobbins, it looks like you're unmuted. Did you have a question? Oh, maybe she's just unmuted. I don't, here we go. Damian, you've got a question?
Yeah, I had to find and plug in my microphone real quick. But so I know in the past couple of weeks, we talked a lot about efforts to get vaccines into rural and underserved communities. Just wanting to check on kind of an update on where that stands and what the future of vaccine administration and programming in some of our kind of least vaccinated areas of the state are.
Right. And Dr. Bell may want to touch on this as well, but I'll certainly get started with it. She actually, I heard her speak quite eloquently, more eloquently than me to this the other day. But, I think Ultimately, we rely on all providers. Certainly, we can most directly control the dhec providers that we have out there. So it is absolutely our goal to make sure with our dhec clinic events that we do everything we can to try to have our ear to the ground and look at data to try to determine where are the areas where we need to focus our efforts. Now, we are only certainly a small part of it, but I think numbers that we've shared in the recent past, certainly the numbers, as I recall, throughout February, well over 2/3 were done in the most rural in our most rural counties, both of the number of clinic events and actually the number of vaccines administered. If you also look on our vaccine dashboard that we have, you can certainly see where residents are who are getting vaccinated, as well as where clinics are being held by geographic area. And I think one of the areas, certainly not the only area, but one of the areas that has historically interested us the most and been the most rural, for instance, and oftentimes the most underserved, is that I-95 corridor, and in particularly just based on sheer numbers of counties that fall into that category in our PD region. And so the rates that we're seeing in some of those areas, it looks like our providers are doing the same thing that we're doing and that we're asking them to do, and that is to look at the data and to look at the rates of vaccination, the numbers per population. And some of those areas, actually, I'm pleased to see we have put quite a bit of focus on, and the numbers from a rate standpoint are looking better than some might anticipate. And so I'm encouraged by that as well. So Dr. Bell, I don't know if you have things that you want to offer, because I know you spend an awful lot of your time with providers and groups around the state trying to beat the same drum.
Yes, and I just, Nick really keeps his finger on the pulse about all the logistics of the, the number of providers, the allocations, the doses that we have coming in. But the other component of that is that as we make every effort to recognize those expectations, recognize unmet needs, and work towards them, that we're actually monitoring how well we're doing. And so with the wide number of providers we have that work together with us to meet those unmet needs, specifically in those rural areas and for underserved populations, all the effort that we put into it, we have to make sure that we monitor how well we're doing it, how well we're assuring access by geographic distribution. And then we look at breakdowns by population group as well. Nick mentioned the area in our I-95 corridor that historically we know there are just a multitude of health problems that individuals who live in those areas suffer from. Similarly for COVID as well, we've recognized higher, not only higher case rates, but higher morbidity in that I-95 corridor. So that prevention and access to vaccine is really key for those populations. So continuing to monitor and measure how well we are doing with utilization, not just geographically but also by subpopulation groups. If we look at the breakdown by racial and ethnic groups, are we administering vaccines in proportion to the makeup of the population of those groups? Drilling down as low as the level of by specific age group and populations of the percent of African Americans in a particular age group. Are we meeting that need by matching the number of doses administered to them that matches the percentage of the population that they make up? And so that's how we monitor if we're addressing some inequities that we've recognized. And like Nick, I'm encouraged that all the efforts that we've put into to making vaccine available to providers, activating those providers in those areas to make sure that we allow access, but not just in those fixed locations. We have to pay attention to transportation issues with mobile sites, pop-up sites. We're paying attention to homebound individuals, so that for those that, regardless of urban or rural, where they are, if they can't leave their homes, then they can't get the vaccine. And we're pleased to be working with other partners to assess the accessibility of even homebound vaccination. So from many, many angles, through many partners, through many provider types, we are monitoring the data, and we'll look at this as we roll into phase 1B. Now that it's available for a wider proportion of the population, we want to see the closing in the gap of that inequity, some of which we saw in phase 1A, which had a lot to do with the fact that racial and ethnic minorities were just not a high proportion of those target groups. So as we move into phase 1B, we're going to continue to monitor how well we are meeting those unmet needs.
I'd like to thank you, Dr. Bell, Nick, and our media guests for your time and commitment to keeping everyone informed about our state's COVID-19 response and our vaccination rollout. Media, you can send any follow-up questions to our COVID Joint Information Center, and we'll work to get those answered for you. And we do plan to hold another 45-minute briefing on Friday. That concludes today's briefing. Thank you for your time.